Okay, let's, if we can now, we're going to bring this home to our final conclusion. I want to, in fact, cover the topic of obesity, inflammation. And as a psychiatrist, I've always been struck by how obesity and its effectors metastasize to the brain. In other words, obesity is an organ. It produces neurochemistries that are relevant to what we're doing. And it is a bidirectional story, that being the central nervous system and obesity. But we're going to talk about where we're at. And admittedly, part of this is like going to Las Vegas and going to those technology shows where there's lots of gizmos, lots of really neat ideas. Some make it to the finish line, many don't. And there's a lot of talk here as the opportunity. We're aware of Gartner's hype cycle. There's been a bit of hype around this, and we'll need to have very careful contemplation as to where this is going to take us vis-a-vis changing practice and helping us in terms of treatments and management options for people who have brain-based diseases. So I'll cover this in some degree of detail. Ben Goldstein's a good friend and psychiatrist. I think Ben is one of the scholars of bipolar research in Canada. You guys all know that people who have depression and bipolar are differentially affected by inflammatory conditions. Cardiovascular disease is certainly not the only one, but this is one that stands out. So whenever someone starts to build the case that there's a platform, a nexus of inflammation relevant to depression or bipolar, one line of evidence is the aspect of comorbidity. There are several psychiatric or mental disorders that are differentially affected by obesity, depression, bipolar, schizophrenia, PTSD, and no surprise, binge eating disorder. And I think that really, in fact, we're talking about a set of disparate conditions that share in common alterations in glucose insulin homeostasis, an imbalance of regulatory and counter-regulatory hormones, and inflammation. Rodrigo Manser is a psychiatrist in our group. Him, along with Yenna Lee, in fact, published this, or took the lead on this paper, which was published. What's the message? If you have diabetes, you have an anti-cognitive condition. This was a summary of extant literature providing unequivocal evidence that diabetes is anti-cognitive in the younger adult and in the older adult. And there are moderational influences vis-a-vis to what degree your A1C is abnormal and how long it's been abnormal for, as well as your body mass index. Let's, in fact, if we can, just quickly now look into the brain. So we know that the brain is not only regulating appetite and feeding behavior, but the brain is also in fact, many ways, the organ that's hazardously affected by inflammation and obesity. And Vincent Chen is a colleague in Taiwan, and Vincent has worked with us for a number of years, looking at a number of different angles of this question, or angles to the question on inflammation, obesity. What's my message? Well, it starts off with a brief, if I can skeletonize the story around the brain, and that's CNN, circuits, nodes, and networks. And I always use this concept that we talk about the scaffolding in the brain as really one where we have these discrete nodal regions that are interconnected not just structurally but functionally, and they're in circuits and networks. And I always found the CNN to be a very useful way to think about it. Then Trump came along and was talking about CNN and fake news. And so then I had to kind of rethink my CNN, because this is not fake news. This is real news, that we have this effect of obesity on the brain structures. And when you delve into the brain, you are finding in obese people not just random alterations in circuits, you're finding effects on those brain circuits that are subserving cognitive control. So to the question around ADHD, there is in fact a clear association with ADHD and obesity, but there's a clear association between executive dyscontrol and obesity. This often manifests as binge eating. And we also know that there are alterations in so-called cue responsivity. Said differently, the person who has obesity will in fact react to a cue, such as a savory food, in ways that are exaggerated, which in fact lead to the wanting. Unfortunately, the consumption is met with a under-reactive experience. The liking is not quite as savory as it thought it would be. And this is an interesting aspect because the reward circuit and the cognitive control circuits are altered. We talked about aging earlier this morning. I briefly mentioned that depression and bipolar prematurely age you. This is a machine learning study that looked at thousands of scans of the brain. What's the message? Obesity ages your brain. And on average, it ages your brain by about 2 years in this particular study. And FEP is first episode psychosis. And we know that if you're normal weight and you are experiencing psychosis as part of mania, for example, your brain's aged. And if you are suffering from bipolar mania and obesity, you have this aggregate effect on your aging process. That's disquieting to me, but it's also interesting to me because what's the mechanism driving premature aging of the brain? So said differently, in psychiatry, we talk about premature aging of our conditions, and we are now seeing this in metabolic studies. Now, this is a really cool study. This was just published before the holiday season at Christmas time. This was a set of neonates, 14 days old. They signed up for a study. These must be very interesting 14-year-olds. I hope that they were compensated appropriately for their time. And like the college students who volunteer for our studies, I hope these neonates didn't take that money and buy cannabis with it. Anyhow, so these are 14-day-old kids. I guess their moms or dads or whatever volunteered them for the study. And what's interesting is that 60% of women who are pregnant in the United States today are obese. And their children, when born, have brains that are different when compared to brains of moms who are of normal weight, adjusted for pregnancy, obviously. And what's really concerning is that the topography of the brain and the tractography, that is the tract interconnectivity, in these 14-day-old kids is abnormal in neonates born to obese moms. And what's really concerning is that the alterations observed are identical to what we see in obese adults. In other words, the transmission of obesity, which we know is up to 40 to 70% heritable, is actually manifesting in a 14-day-old neonate in those same 4 brain regions that is affecting the adult. So these things are laid down very early and involves, no surprise, cognitive control, reward areas, sensory cue areas, as well as motor areas. And this has been seen over. If we actually zoom in and begin to look at the cellular systems, we actually observe that the neurons and the glia are actually shrinking in size and dying off at an age much sooner than expected. That's apoptosis. But because it's driven by metabolism, we coined this new moniker metaboptosis, because it's driven by metabolism along with the aging due to inflammation, which we call inflammaging or immunosenescence. So you have this combustible mix of inflammation as well as bioenergetic alteration jeopardizing neuronal and glial integrity and survival. Rodrigo had access to post-mortem brain, and we gathered this from the NIH, and he ran this analysis looking at gene transcripts. And we were interested in the effect of obesity on post-mortem brain. Specifically, what was the effect on a couple of key targets relevant to what we do clinically. We looked at the insulin receptor system because insulin is so critical to reward and cognition. We looked at dopamine, so critical to motivational experiences. And that's acronymized as DR2, DR5. DAT's dopamine transporter IRS1 and 2 is the insulin receptor system. VMAT is the vesicular monoamine transporter. What it does is it reuptakes dopamine from the cytosol into the vesicle for release with depolarization. The reason why when you have the flu you feel so apathetic that first day is because VMAT downregulates, and hence dopamine cannot get inside the vesicle for release. And by the way, one of the treatments for tardive dyskinesia is a drug called tetrabenazine, which is a VMAT2 inhibitor, and it reduces dopamine release. But the point I want to get at is that in postmortem brain, specifically in the prefrontal cortex, we see an alteration in insulin and dopamine expression, and it's moderated by obesity. Long story, made short, is that obesity is being influenced and is influencing key targets for reward, motivation, and cognition. It keeps coming back to this area. Now, to keep going, we know that we have elevated inflammation in the periphery. We have elevated inflammation centrally. And when you have elevated inflammation along with abnormal metabolism, neuroscience math is 1 + 1 = 10. So here's a protein called DPP4. What the hell is that? Dipeptidylpeptidase. That is an adipokine. It is pro-inflammatory. It's also involved in breaking down incretins, like that are involved in insulin secretion, etc., which I'll come back to. And the message is, in this 3D diagram, in the distant sort of corner there, standing in the corner like a bad boy, misbehaved. I spent a lot of time there. I remember those days. Anyways, but CRP multiplied by DPP4 equals a lot of depression. So we're talking about these two systems, inflammation and altered metabolism, increasing the risk for depression. I also, in fact, am cognizant that inflammation's cross-talking. So it's cross-talking not only to other inflammatory and metabolic systems, but when you're in a state of inflammation, it causes a significant reduction in the availability of certain monoamines, like serotonin, dopamine, norepinephrine, and this likely contributes to the anhedonia, the cognitive impairment, the psychomotor retardation, the depression that we see in inflammatory states. Now, this is, in fact, an attempt to bridge peripheral to central. The message is the more you're inflamed, the less likely your reward circuit is functioning normally. And the reward circuit is well sussed out in the CNS. This has been replicated. By the way, for those who are interested, this story really, in fact, has a modern history beginning in the late 1800s by a person you all know, named Dr. John Harvey Kellogg. And Dr. Kellogg, of course, authored your cornflakes. And Dr. Kellogg ran a facility in Battle Creek, Michigan. And in Battle Creek, Michigan, where the Kellogg's Museum is, which actually is worth checking out. Battle Creek is kind of a lame city, but the museum is very interesting, and goes into great detail as to why they developed cornflakes. Does anyone know the story? It's a great story. You can't make this up. He had observed that when patients on the ward consumed carbohydrate, the patients would report to the nursing staff they felt less anxious. You think, oh, makes sense. I can relate to that. That makes good sense. And he conjectured that what was happening was there was a spike in glucose. And the spike in glucose was, in fact, doing a couple of things. First, it was sedating people. It was sedating them because there was a transient reduction in the availability of dopamine. And he had these thoughts around this, or other neurochemistries that they thought were related to this. And so he came up with the great idea that he was going to develop a carbohydrate to assuage the anxiety of his patients on the ward in Battle Creek. So he created this corn, milled product. And it worked. The patients said they liked the taste of it, and they were less anxious. But here's the zinger, and this is the part so interesting. He was a very religious man, and he thought that if you are anxious, you're more inclined to masturbate. And he thought that masturbation was, in fact, unhealthy and inappropriate. So he created cornflakes to reduce masturbation. So, I won't ask for a show of hands, but when I walk down the aisle of Loblaws and I see somebody picking the cornflakes off the shelf, I always think to myself, I want to ask them, does that reduce your masturbatory urges? Anyway, that's a true story, but it brings us back to something. He was an interesting guy. He was a very bizarre guy. Thank God for him that his brother was a real businessman. They both became very wealthy selling cornflakes, but that's a true story. But the bottom line is that we know carbohydrate has this ataraxia. That's the word. It's where the name atarax came from. The benzodiazepine was borrowed from ataraxia, which is kind of a tranquility without sedation. And that's what he wanted to achieve with carbohydrate and with yogurt. So now we bring it forward. We're a little more rigorous, I think, now. We're not as concerned about masturbation. And we certainly are, in fact, interested in sussing this out because inflammation, which we see in depression and obesity, drives the depression. We know that. It also drives the anxiety. And it makes good sense because why were we inflamed hundreds of thousands of years ago? It wasn't because we were obese. We were inflamed because you had an infection or you had a wound. If you had an infection or a wound, you were subject to predatory attack. You also, in fact, were in a situation where you needed to conserve your energy. So when you're obese and or when you're depressed today, your immune inflammatory system activates. Consequently, you see activation of the anterior cingulate cortex, which leaves you anxious. You also see psychomotor retardation, which originally was to preserve energy, but now it manifests as depression, anxiety, irritability. This is why we conjecture obesity is making patients more lethargic, anhedonic, and making them so anxious. This is a very nice characterization. This is only 6 patients. No one's going to say 6 patients is a sample size of 500 patients, but something very elegant here. That red line represents diabetes. These patients had bipolar illness, and as soon as they had insulin resistance, that is, they had prediabetes, their bipolar went south. Lots of episodes, relapses, depressions, manias. And the point is that we need illness modification. We need disease modification in psychiatry. And it's very clear that the presence of diabetes or obesity is disease-modifying major depression and bipolar. That's the bad news. The good news is maybe we can target this system to get us, in fact, on the right track. Now, we talked about ketamine this morning, earlier. It seems as though, based on literature, that patients who are inflamed may, in fact, be more likely to respond to ketamine. In fact, there's some evidence that people who are obese may be better responders to ketamine in some studies. The only other drug that comes to mind for me that behaves that way, that is performs better in people with higher body mass index or who are inflamed, that is performs as an antidepressant, is L-methylfolate, which I've been quite underwhelmed with, but it seems to perform better in people who have altered metabolism, that is elevated leptin or altered inflammation, increased CRP or increased BMI. And this recent paper was just published a few weeks ago showing that people with bipolar disorder who are prescribed a statin or prescribed metformin, which is a biguanide, are less likely to be hospitalized or engaged in self-harm. So we have this clinical data, we have this population data that's given us a reason to believe, and it's always difficult to believe what's not believable. To wrap this up, here's 2 other anti-diabetes drugs. One's called Januvia, and one's called Forxiga, vitagliptin and dapagliflozin. These are, one drug's a DPP-4 inhibitor. DPP-4 causes depression. And dapagliflozin is a SGL2 inhibitor, and it is a drug that allows you to urinate out sugar. This is a drug approved in Canada. And it turns out when rats are made fat by giving them a high-fat diet, it turns out that these two anti-diabetic drugs behave as brain protectants. They reduce apoptosis, they reduce oxidative and inflammatory stress. Another drug that we very frequently use in the clinic is liraglutide, which is used for weight loss. It's used for diabetes. This is 1-year data, RCT, randomized controlled trial data, demonstrating that liraglutide has favorable influences in schizophrenia on a variety of metabolic and BMI parameters. Big issue because we in psychiatry struggle with weight-related morbidity, particularly drug-induced from some of the weight gain promoting drugs. So when asked on the exam which drug has been most studied with the most weight loss and metabolic favorability, it would have to be this drug, liraglutide. And we're starting a study now looking at the combination of naltrexone bupropion and its effect in this population. So we funded this study through my foundation, and liraglutide is, again, as Saxenda in weight loss as Victoza in diabetes, has been shown to engage the brain in the dorsal lateral prefrontal cortex, the same part of the brain that we see as abnormal in postmortem brain, and was able to increase the neuronal viability as evidenced by increase in acetylaspartate levels, and it also increased cognitive performance. So Victoza 1.8 to 3 milligrams has been one of our go-to off-label drugs to improve cognition and improve reward in patients with or without obesity who suffer from depression or bipolar illness. Mediterranean diets look promising. I think Harpreet spoke to this. More work is needed is almost the bromide, but indeed more work is needed, but certainly some promising evidence that these diets may in fact be adjunctive. I don't see them as being the cornerstone of therapy. I had a lady in St. Louis tell me not that long ago that she tells all her patients to eat yogurt for depression. And it sounds very interesting. I like Chobani yogurt, tastes lovely, but I don't think it's actually a treatment for depression. Prebiotics and probiotics have caught on the hype cycle, Gartner's hype cycle. It's way at the top of that expectation, frankly, and we'll need to actually have some careful thought around this. There's no question that altering the gut biome has brain effects. We're starting to see that in studies like this, using prebiotics and probiotics. And there's no doubt that when you manipulate the biota of the biome, that could have some antidepressant effects. Minocycline might or may not be doing this. Josh Rosenblatt. If you haven't noticed that I'm just standing here today just citing all the work of students who work at my clinic. So I got to thank them for, well, making me look good. So anyways, so minocycline, in fact, behaves as an antidepressant. It stabilizes microglia. It's an anti-inflammatory drug. I use this very commonly to treat depression that's been uncooperative with existing therapies. Doxycycline may be similar. We don't know. And looking at a summary of anti-inflammatory agents, well, first of all, the bottom line is they seem to work, but I would just then say each class is different. Steroids clearly are not where we want to go with treatment. They worsen psychopathology. NSAIDs may interfere with SSRI efficacy. Aspirin looks very promising. Minocycline we talked about. Omega-3 doesn't really work, but it works in a small group, interesting that small group that has elevated CRPs, elevated TNF. And it kind of makes sense given what we think about that particular drug. Finally, this is a paper in Press in JAMA. This study was one of the most difficult, and frankly, the most difficult study I've ever done in my life. This was giving patients infliximab, the TNF-alpha antagonist, to improve depression. And it turned out that in patients with abuse, physical or sexual abuse, which is unfortunately half of our patients, they actually significantly benefited from this treatment. And we know that exposure to trauma activates what's known as the inflammasome. And that can lead to diminished response to SSRIs and conventional approaches. So the idea that an inflammatory drug could help a subset that has this history of trauma is obviously something we desperately need in psychiatry. Finally, I made reference to senolytic drugs. This is one called AP20187 that we're working with. And this is a drug that looks for TAF. Now, what's TAF? TAF is a marker of aging inside your cells. If you ever meet TAF at a party, avoid TAF. TAF makes you older. And so just say thank you, but I'll talk to you later. But TAF is bound up by this molecule, this AP20187, and when that happens, it reduces apoptosis. The cells stay alive longer. And details, again, for another time, but the concept is we're trying to figure out which proteins inside the cell or organelles that we can target that can, in fact, begin to disease modify. Elephant in the room, get a good night of sleep. That's anti-inflammatory. That's been well described. And neurostimulation is also anti-inflammatory, as is psychosocial treatments. So this is clearly convergent. We all prescribe anti-inflammatory agents. It's called psychotherapy, it's called neurostimulation, and it's called medication. So this is clearly an area that's going to be with us for a little while. I think we're still on the hype curve. We need to get into that kind of slope of, I think, careful consideration. And in the interim, manage that weight. This is a nice review by Harpreet Gill, a new master's student who has in fact shown that bariatric surgery clearly attenuating depression and attenuating anxiety. So in short, I hope you don't remember from this presentation only the masturbation story, but I hope in fact you at least take away that we've got lots here to think about, lots here to work with, and clearly lots that we're going to be pursuing in the very near future.